Hello. In critical care, few things test our skills like a patient in circulatory shock. How we act in those first critical hours often dictates their entire clinical course. And I'm here to tell you, the evidence has just given us a new roadmap. You know, when we're facing a patient in shock, we're up against mortality rates that can soar as high as 50%. It's a stark reminder that staying current isn't just important, it's an absolute necessity. That's why these new 2025 guidelines from ESICM are so pivotal. They are truly practice-changing. I'm Dr. Mech, and welcome to the Dr. Mech Explainer series. Our goal here is simple, to break down essential medical guidelines into clear, actionable insights that you can use in your daily practice. Now, just a quick reminder, this content is for educational purposes only. It should not be taken as a substitute for your own professional medical judgment. The information in this explainer is taken from the following source. All right, we're going to walk through this just like a real clinical case. We'll start with defining and recognizing shock, then talk about fluids and advanced monitoring, look at the role of echo, and wrap up with the most important takeaways. So let's start at the very beginning, the foundation of our diagnosis. The new guidelines give us a more refined way to think about what shock is, and, just as importantly, how to spot it at the bedside. So the 2025 panel from the European Society of Intensive Care Medicine provides us with this updated definition. What I want you to notice is the real emphasis on the core problem, that fundamental mismatch between what the cells need and what we're able to deliver because of poor tissue perfusion. Now, clinically, this is where it gets really practical. The guidelines recommend we assess for shock by looking through these three windows of hypoperfusion. This gives us a fast, non-invasive way to make the diagnosis right there at the bedside. And this is a key point. A lactate level over 2 is now formally recognized as a typical feature of shock. This really solidifies its role as a critical diagnostic and prognostic marker for us. Okay, next up is fluid management. The new guidelines are really pushing us towards a more dynamic and, frankly, a more intelligent approach to resuscitation. This really is the million-dollar question in managing shock, isn't it? After you've given those initial fluid boluses, what do you do next? How do you decide if more fluid is actually going to help? And here's the answer. The guidelines issue what they call an ungraded good practice statement. Essentially, they're saying that after that initial phase, you should be formally assessing for fluid responsiveness before you just hang another bag. It's all about avoiding fluid overload. In this slide, this illustrates one of the biggest shifts in the entire document. The panel is coming out strongly in favor of using dynamic variables. Think passive leg raising or pulse pressure variation. They are telling us to use these tools to predict fluid responsiveness. On the flip side, those old static markers like CVP, they are explicitly not recommended for this purpose anymore. So what about those patients who just aren't turning around with our initial therapies? The guidelines give us clear direction on when to escalate to more advanced hemodynamic monitoring.
This is a crucial decision point. At what point do we say, okay, we need more data? When do we need to escalate to invasive cardiac output monitoring to really get a handle on the patient's underlying physiology?
Again, we get a very clear, ungraded, good practice statement here. For any patient who remains in shock despite your initial efforts, cardiac output monitoring is indicated. It's all about clarifying the phenotype of shock and guiding your next therapeutic steps. Now, this table is incredibly useful for day-to-day practice. It guides our choice of device based on the specific clinical picture. For example, if you have a patient with shock and ARDS, a transpulmonary thermodilution device is preferred because it can measure extravascular lung water. But if you're dealing with shock complicated by right ventricular failure, a PA catheter is the better choice for its ability to directly measure PA pressures. All right, let's talk about imaging. The guidelines are placing a huge emphasis on echocardiography, really making it a cornerstone of modern shock management. You're watching the Dr. Mech Explainer series. Now, this is a weak recommendation, but it's an important one. The panel suggests using echo as your first-line imaging tool. And it makes perfect sense, right? It's rapid, it's non-invasive, and it gives you a wealth of information about cardiac function and volume status right at the bedside. And it goes even deeper than that. The guidelines point out that specific findings on the echo, things like different phenotypes of LV and RV dysfunction, can actually carry significant prognostic weight, helping us to risk stratify these very sick patients early on. Okay, let's bring it all together. What are the most critical, practice-changing points that you need to take away from these new guidelines? So, to summarize the absolute must-knows, First, use those 3 clinical windows, skin, urine, mental status, to assess perfusion. Second, after your initial resuscitation, you have to use dynamic variables to guide further fluid therapy. Third, in refractory shock, it's time to escalate to cardiac output monitoring. And fourth, get that echo on the chest early and often. It's your #1 imaging tool.
So as we wrap up, I'll just leave you with this question to think about. Which one of these updated recommendations, maybe it's the big shift to dynamic variables or the emphasis on early echo, which one is going to most directly change how you manage your very next patient in shock? Thank you for joining me for this edition of the Dr. Mech Explainer series. To make sure you stay current on all the essential updates for your practice, go ahead and subscribe and be sure to enable notifications.